until morning session is over. So until we're already going.
Off schedule.
I mean, not off schedule. Like the timing. Like
So they will be seen this way, huh?
Yeah, the student will be here, and the student will visit it here.
So we are doing
Can you adjust one?
So you will be on YouTube. Overnight celebrity for the day. I think
Just
the
nice.
table needs to be a bit further than the chair because they will absolutely.
Okay. Nice. This is nice.
Try to sit. Try to sit.
Try to sit. Try to sit.
You should be able to get the view of.
yeah, getting the view. My face
that
is
one
straight.
and
Who is the participant will
the
talking to
participant
you?
will
Look there. Not
us.
you. Okay.
We will be only two more.
Like this one.
We
I
will
see.
only mark them. So
So you're just marking us, so they
Yeah.
face there and speak
Yes.
to the monitor. Okay.
So the way that they mention things and the way that
Okay. Yeah. Okay. Mr. Lodi.
visible.
But this one face is not.
Come here.
Okay. Then.
This good.
Yeah. That's.
Go.
Thank you.
University.
Manipal.
The team name.
Lynx. Lynx. Lynx.
LY.
Yeah. So for this patient, verbally abusive, irritable, threatening family members with a hockey stick, and belief newsreader was talking about him. So most likely he's having a diagnosis of schizophrenia, and then he's been hearing external auditory voices. And also there's he believes that the newsreader was talking about him, so there's like thought broadcast, and then
I think we need to do that first.
see muttering to himself. Should I just continue? Huh? Oh, okay. Oh, okay.
We can also.
Okay. So there was thought broadcast that was noted, and then there was psychopathologist. There was irritability, thought broadcast. Ask the patient, does he hear any external voices, and then does he hear any commands that asks him to do anything, and then does he listen, how many voices does he hear, is it usually like a single voice, or is it multiple voices, and then are the voices like discussing about him, or are they like talking to him, if it's first order or second order, and then to differentiate whether it's true or pseudo hallucination, and then see if the
You can reduce the sound. You cannot hear.
So ask does he have any suicidal thoughts, like has he thought of ending his life or things like that, and then at the same time ask if there was any family history of similar complaints, and then is there any family history of suicides that has happened in his family, and then to the family ask how. So immediate management would be first of all to start the patient on symptomatic control, so start him on benzodiazepine and beta blockers, and then at the same time start him on atypical antipsychotics like olanzapine and quetiapine, because he's been having symptoms of schizophrenia, and other than that also counsel immediate management. Yeah, that would be the immediate management. And also in case if the risk is high, then based on what we assess, then also to admit him to the wards and also start him on electroconvulsive therapy in case if he's being having a high risk. And if the
To make it louder because he said it's
so based on what I observed, it's that he's been having tremors in both his hands, and then at the same time he has his neck that is turned towards the opposite side. So dystonia and Parkinson-like symptoms. Most likely cause of his condition is the adverse effect of antipsychotics. Possible that he was prescribed on typical antipsychotics, which commonly cause this symptoms like Parkinson-like symptoms, and at the same time dystonia and all. So for now, stop the antipsychotics, typical antipsychotics that are causing him the symptoms, and at the same time start him on maybe atypical antipsychotics which have lower risk of causing all these symptoms, and also to give the worst drug like that's all. And that also to do like cognitive and behavioral therapy for the patient, and then at the same time to do, if it's resistant to all these, then also start the patient on electroconvulsive therapy. Thank you.
Corvus. Can I take a seat? Or?
Yes.
Thank you.
We'll read the case first.
Persecutory delusions, disorganized behavior, disorganized speech, and he has poor hygiene, reluctance of hygiene as well. Yeah. Okay, so regarding the persecutory delusion, I would like to ask if it's due to another person talking to him or if it's due to from this itself. And then I would like to ask the duration of the delusions, and I would like to ask if there's any family history of the similar diagnosis. And I would like to ask if there's anybody talking to him, and if they're talking to him, if they're not talking to him, if it's like if two people discussing about him, or it's three people discussing about him, or they're talking to him straight. And I would like to also ask if he. Okay, for the risk assessment, the first one is he has a risk of harming himself as well as harming others. And second, he has risk of aggression and psychosocial, poor psychosocial behavior because he has reluctance of his own hygiene. So my risk assessment is that he has to be admitted inpatient for further management. Yes. He has quite high risk. Okay, since he became aggressive, my first one is to do de-escalation therapy. For de-escalation, I will start off with verbal de-escalation. If verbal de-escalation does not work, I'll proceed with chemical restraint, which is I will start off with intramuscular haloperidol. Or since he has experienced schizophrenia, I'll probably go with oral olanzapine, Zydis. And then after that, with that, I will also prescribe him benzodiazepines, midazolam, midazolam, to help with the management. And I would like to for further management, I'd like to ask the family members. And before that, if the chemical restraint doesn't work, I'll move on to physical restraint, 4-point restraint or 2-point restraint. Yeah.
What happened to you, sir? Can you look at me? Can you put your head and look at me? What do you feel? Okay.
I think he has tremors of his hand as well as tremors of the legs. So it could be the side effect of the medication. So I think it could be acute dystonia. Yes. And yeah, there's increased tone of the muscles as well as tremors of the hands. Could be due to the side effect of the medications. You could be taking typical antipsychotics, which could lead to all these side effects, such as acute dystonia, Parkinsonism, tardive dyskinesia, akathisia. So it could be a side effect of the medications. Now I'll probably study to reverse the side effect of the medications. I'll study anticholinergics, probably Artane, trihexyphenidyl, to reverse the current condition. And after that, I will stop. Probably if he's taking first line antipsychotics, atypical antipsychotics, I will change him to atypical antipsychotics like risperidone, olanzapine, quetiapine. So after that, I will move on to his further management, like cognitive behavioral therapy or psychodynamic psychotherapy, psychoeducating the patient as well as the family members, and psychotherapy as well, and family counseling as well to help manage the disease. Thank you.
please answer after the question is
Oh, okay.
Appear there.
appear there.
Alright.
And then please say it clearly and loudly, but just look at the screen but say it clearly and loudly.
Okay.
Okay.
First would be delusion, because he thought that someone's going to treat him, and then other is thought broadcast, thought insertion, hallucination. Okay, you may ask 3 important questions to help establish the diagnosis. So, how many time does he have these episodes, and does he comply to his medication? Does he have any suicidal attempt? Are there any other hallucination symptoms like seeing other things, hearing people talking? Okay. The patient has a known diagnosis of schizophrenia, has been expressing both psychopathy and personal arbitrary association. He believes his neighbor is sending ill charm to his house and causing harm to him and his family over the past few years. So risk assessment. So this patient is a high risk because he wants to harm himself and harm other people around him. And then he also have Snyder first rank science symptom, which is the person hallucination. And he is become more increasingly irritable. And what is your immediate management? So, firstly, if it's in aggressive state, so I would like to de-escalate this person by giving physical restraint, and then it's for only short term, and then I will do the chemical restraint using haloperidol or midazolam, and then when the and then for long term, I'll be giving psychosocial treatment like CBT, and make sure patient comply to his medication, which is.
What happened to you, sir? Can you look at me? Can you move your head and look at me? What do you feel? Okay, right.
So the patient is having a tremor on both of his hand, and then his. Okay. I think this is condition called tardive dyskinesia, or because of the side effect from the first gen antipsychotic. How would you manage him? So by giving him benzodiazepine, and then stop the first gen antipsychotic. Uh,
You can answer whoever you want, Mr.
um, uh, keep on thank you thank you thank you
Just look at the screen,
Okay.
and once the question appears, you can answer.
Sure.
You can answer before that. And please speak loudly and clearly.
Okay. You. I was talking about. Is the question up yet? Okay. Okay, three psychopathologies. I think he has auditory hallucination because of he's talking to himself, and also there is a persecutive delusion. He thinks the person in the television is talking about him, and also there is disorganized behavior. He's being aggressive towards the patient, to his family members. Three important questions. I will ask auditory hallucination, whether he's having any auditory or visual hallucinations, and also whether confirm the delusion, whether it's a persecuted delusion, and also next is whether any disorganized behavior, any change in concentration. Like since he's having a problem with the academic performances, I would think that there's inattention and disorganized behavior as well. For risk assessment, first I would like to ask, again, confirm the auditory hallucinations, whether it's second or third person, and also ask for any delusions, and also ask for his other symptoms, and then ask whether he has any plan of harming other people, and also whether he has the means, the tools to harm other patients, and whether he has any increasing in anger, any risk, previous history of aggressive behavior. On my immediate management, first I would like to de-escalate the patient, de-escalate the situation. First, I will confront him, and let him know that we are here to help. There's no need to be aggressive, and then if verbal confrontation is not useful, I would go probably physical restraint, and if physical restraint is after that will be quite chemical, such as antipsychotics, first generation like haloperidol or any olanzapine as well, injection for fast acting.
What happened to you, sir? Can you look at me? Can you look your head and look at me? What do you feel? Okay, right.
So there's a patient cannot move his neck, so I think there's dystonia, and there's also Parkinsonism, tremors, involuntary tremors over the peripheries. So I think this is extra pyramidal symptoms. The most likely cause is adverse effect of the antipsychotics, probably haloperidol. So this will likely present with dystonia, akathisia, and also Parkinsonism. So I think it's extra pyramidal manifestation. So how I manage him now? First, I'll assess the patient as a whole. I'll start assessing and resuscitating him as per the ABCDE protocol. And next, if patient is stable for the vital signs and he's still breathing well and the vital signs are stable, I would give him benztropine as an anticholinergic agent to reverse the effect of the antipsychotic haloperidol. So apart from that, I will, if there's any secretions, I will use a suction to remove the secretions, and as well as if the muscle contraction is too strong, I will give some muscle relaxants as well, such as okay,
Thank you.
so fast. Thank you.
Okay. The three psychopathologies in this patient can be delusion of um, reference, aggressive behavior, auditory hallucination. First, I will ask if the patient can hear other voices outside from my voice, and if the patient can hear the voice inside or outside the head. And then I can ask about if the patient has any, if the patient feels there's a thought that being inserted into his mind or will withdraw. So the risk assessment I will do to him is aggressive risk assessment, which is if the patient has any intention to risk himself or others, any plan to do so, and also any accessibility to the weapon. Okay, so the immediate management, if because the patient has causing harm to the family, so we have to admit him to the hospital, and also we have to do the escalation. We have to do physical restraint if needed, and give diazepam, and also antipsychotics medications like haloperidol, the second generation, and risperidone. And we also have to send laboratory investigation like the full blood count, thyroid function time, cellular function time, renal function time, cellular function time to rule out the organic causes.
What happened to you, sir? Can you look at me? Can you move your head and look at me? What do you feel? Okay, right.
So the patient is showing tremors, and also the patient's response to the questions. He is what can I say, cooperative, but he cannot move his neck, obey the command to move his neck. That's like the causes of addiction. It can be because of the side effect of the antipsychotic medications. How we manage? You can give muscle relaxant.
Anything else you would like to add?
Okay, muscle relaxant. You can give some. No idea. Thank you. Thank you.
And your group name is?
Monocerus. Monocerus.
Please answer clearly and loudly. Only answer after the question.
So I can see that this is a.
Wait, yeah, wait. There will be a question of you.
Sorry about that.
It's fine.
So I can see that this patient has got disorganized behavior as evidenced by his using the force and violence. At the same time, this patient also has got delusion as the patient can actually perceive that the television is trying to hurt him. So that's some form of persecutory delusion and also disorganized behavior and thought. Okay, so can I please ask the patient, do you actually feel like someone is putting thoughts into your head, or either someone is deleting thoughts or someone is trying to harm you? At the same time, can I also ask you if that you feel something moving over your hand, or you smell something unusual, or you see something that's not present, or you can taste something that's not present for hallucination? And at the same time, I also want to ask the patient if got any wanting to hurt someone else. So my risk assessment of this patient is that currently the patient is aggressive. He's been having hallucinations. So I think that this patient has the potential to behave aggressively, and also homicidal and suicidal risk. So I think this patient would need careful workup and treatment in a hospital-based setting. Yes. So because the patient is harming the family already with the hockey stick, I think this patient would require immediate admission into the hospital, and at the same time looking at his current state to talk to him and to verbally de-escalate the patient, and also to call for help and to get the nurses to prepare if we need any IM haloperidol to calm the patient down. But before we use any chemical restraint, we want to try to talk to the patient, verbal de-escalation, and ask what medication he has already taken, and if the patient is on any antipsychotics that hasn't worked, so we don't repeat them. But if the patient is still in unrest, we can give him some sedative, like for example, IM haloperidol or diazepam, calm him down, and then refer to inpatient psychiatry for further assessment.
What happened to you, sir? Can you look at me?
So I can appreciate that the
Can
patient,
you look at me? What do you feel? Okay.
So what I can see is that the patient is tremoring, and there's a dystonia where there's a torticollis or head version to the left, and I think the eye is also upversion. So this is usually indicative of acute dystonia when you start patient on antipsychotics and they are naive, or either the dose has not been adjusted properly. So I think this is, as I said, due to the action of antipsychotics, which are dopaminergic agonists as well, and they can cause excess cholinergic activity, which causes muscle hyperspasm and activity. So there's torticollis and dystonia where the head turns to one side and the eye wards.
So as the patient currently has acute dystonia, I think we need to give him anticholinergic agent. We can try trihexyphenidyl benztropine. At the same time, I want to stop the antipsychotic that he's taking. And then because he's also looking like he's a bit unrest, check his vital signs. Is he in tachy? Is he any fever? Because he also can think of neuroleptic malignant syndrome. So we want to make sure his vitals are stable and stop the antipsychotics, start him on anticholinergic agents to help with the dystonia, and then monitor his vitals. And then make sure that he's showing clinical improvement. If not, then we need to maybe seek further help, and after the ABCDE is done, see if there's need for anesthetic agents and any sedation and induction and monitoring in the ICU.
Thank you.
Thank you.
Sorry.